Welcome to Deep Dive Ortho. Today we're taking you right into the heart of one of the most high-stakes environments in medicine, acute trauma care. I want you to picture it. A major road traffic collision, maybe a mass casualty incident. In those moments, time is everything, and your ability to assess a patient dynamically in real time. Well, it isn't just helpful, it's profoundly life-saving. The issue is our standard methods, which rely on intermittent manual checks. They just can't keep up. A patient's condition can change in the blink of an eye. So today we're tracking a monumental shift. We're moving towards sophisticated digital health solutions. We're talking about integrating cutting-edge wearable sensors with the predictive power of artificial intelligence. The goal, a system that constantly tracks a patient's status right from the triage stand. This technology really could be the next great evolution in trauma triage and has massive implications for orthopedic trauma management. And joining us to guide this deep dive is Professor Mo Imam.
Thank you. It's a pleasure to be here. I think the critical starting point for this discussion has to be a really honest look at our current limitations. We rely on these traditional severity scoring systems, the Glasgow Coma Scale, GCS, the Modified Early Warning Score, or MEWS.
The revised trauma score.
Exactly, the RTS. And while they are invaluable, they all share one fundamental constraint. They're static. They are discrete measurements in time. They require a trained professional to be there, to observe the patient, calculate the metrics, manually input the data. The whole process is time-consuming. It can be subjective. And crucially, it only gives us snapshots of what is, by its very nature, a dynamic process. So in a situation where your resources are stretched thin, an MCI, a heaving A&E department, or even a remote pre-hospital setting, that kind of static evaluation is it's grossly insufficient for continuous tracking.
You could miss something critical in the 5 or 10 minutes between checks.
Precisely. Imagine a patient who seems stable one moment and is collapsing the next from an occult bleed. You need automaticity. You need a constant watch that never gets tired. So our mission today is really twofold. First, we're going to meticulously dissect the development and the clinical validation of these innovative digital scoring systems. These are systems designed to replace, or at the very least augment, human intervention in that acute triage phase, offering a dynamic view of a patient's instability. And secondly, we'll pivot. We'll look at how these exact same wearable technologies and AI systems are fundamentally reshaping the long-term prognosis and management within orthopedic rehabilitation, specifically how they're addressing that endemic problem of patient compliance.
That distinction you made between static snapshots and dynamic streams is absolutely vital. And if we're aiming for a robust automated system, it has to be based on metrics that are, they need to be physiologically significant, but also reliably accessible via commercial-grade wearables. So let's focus on this new development. This severity scoring system adapted for continuous monitoring. What physiological parameters were chosen as the foundation for this new score, and why those ones specifically?
Yes, the criteria for selection were really about clinical relevance, ease of measurement with non-invasive wearables, and, I suppose, their sufficiency to characterize basic life support status. We arrived at a score we call SHRO. It's calculated from 3 core physiological signs: heart rate, or HR, respiratory rate, RR, and peripheral oxygen saturation, SpO2.
So why those 3? What makes them the magic combination?
Well, collectively, they provide a really robust, minimal data set you need to characterize patients' immediate hemodynamic and respiratory status. Heart rate gives you a critical window into cardiac output, the body's response to shock or pain. Respiratory rate is often the earliest, and I think the most reliable, indicator of a severe physiological derangement, things like acidosis or early shock.
It's the one that often changes first.
It is, yes. And SpO2, that's obviously non-negotiable for assessing how efficient gas exchange is. Using just these 3 allows for rapid, continuous measurement, even with relatively basic patch or wrist-worn devices.
And how is this score actually structured? It's not just about reporting 3 separate numbers, is it? It's translating them into one unified severity score.
Exactly. The score ranges from 0 to 100. And, in line with established clinical logic, a higher score always signifies a more critical, more severe medical condition. This score is then mapped onto a very clear, actionable triage tricolor code, which directly mirrors established protocols like the START algorithm that's widely used in mass casualty incidents.
So it's immediately intuitive for first responders.
That's the idea. The clinical color codes are defined by set intervals. 0 to 33 is green, which signifies a low priority or stable condition. The interval from 33 up to 67 is orange. That designates an abnormal or delayable priority case. So, a patient needing attention but not immediate life support. And then anything from 67 up to the maximum of 100 is classified as red, demanding urgent, immediate intervention.
And that color coding is the critical translation layer, isn't it? It's what makes the data immediately useful in a chaotic environment.
It is. It removes the cognitive load of interpreting three numbers and just gives you a single, clear action point.
What I find fascinating about developing a new composite score like this is how you establish those precise boundaries, where green stops and orange begins, for example. You couldn't just borrow thresholds from other scores because they operate on different scales. So how did you methodologically establish the boundary conditions for the individual parameters that feed into the score?
That's a great question. And that's really where the rigor of the methodology had to come into play. We had to create a functional mathematical model for the intermediate scores, the score for heart rate, for respiratory rate, and so on.
Yeah.
This model had to translate the continuous raw physiological data, 110 beats per minute or 15 breaths per minute, into a score between 0 and 100. We opted for a sigmoid model, or an S-shaped curve,
Why that shape specifically?
because it naturally reflects how criticality increases. It starts slowly, and then it accelerates rapidly as the physiological parameter deviates further and further from the norm. It's not a linear relationship. For heart rate and respiratory rate, the function is actually a bit more complex because criticality increases at both extremes. A heart rate of 30 is just as dangerous as a heart rate of 150.
Of course.
So the function has two segments, creating a kind of U-shape where the trough, the score of 0, is the normal range. For SpO2, it's simpler. The function is monotonically decreasing because 100% is optimal, and the score only ever increases as your saturation falls.
So you have the mathematical shape, but you need to anchor it to clinical reality. How did you define the points where the score actually hits 33, crossing from green to orange, and 67 from orange to red?
That was done through expert consensus. We conducted a comprehensive survey among 54 expert French health professionals, all affiliated with the Société Française d'Anesthésie et de Réanimation. Their collective wisdom, their clinical experience, provided the essential consensus on the physiological ranges that define normal, abnormal, and critical states for an adult.
Could you give us a concrete example of those expert-defined boundaries, particularly for the red category? Where exactly does a patient move from orange to red based on that consensus?
Absolutely. Let's take respiratory rate, measured in breaths per minute. Based on the expert survey, the green range, so a score between 0 and 33, was defined as 12 to 20 breaths per minute. Normal. Now, the boundaries for criticality are very sharp. Anything below 8 breaths per minute, which is severe bradypnoea, or above 30 breaths per minute severe tachypnoea, is immediately classified as red. It generates a score of 67 or higher. And for oxygen saturation, for SpO2, the critical shift occurs below 85% saturation. Once a patient hits that threshold, the system dictates an immediate red score. These specific values were the clinical inputs that shape the mathematical sigmoid functions for each of those intermediate scores.
That reliance on expert consensus really does give the methodology clinical credibility. But there's a final layer of complexity, which is the merging function, the FMERGE. This function has to reconcile 3 separate scores into one global SHRO score, and it has to do it safely. It has to ensure that a single critical problem, say a red SpO2, even if HR and RR are green, always results in a red overall triage color. How is that clinical logic mathematically enforced?
The FMERGE function is designed as a rigid filter. It ensures that clinical logic always overrides a simple averaging of the scores, which would be, well, catastrophically dangerous. It adheres to 2 non-negotiable logical rules. Rule number 1. If any of the component scores, heart rate, respiratory rate, or O2 sats, is classified as red, meaning its score is 67 or above, then the global score, the SHRO, must be classified as red.
No exception.
No exceptions. We do not compromise a critical finding by averaging it down with 2 normal findings. It's a hard stop. And rule number 2 follows that logic. If no component is red, but at least one component is orange, then the global score must be orange. Only when all 3 intermediate scores are green does the patient receive a global green score.
So it's a conservative approach. It defaults to the highest severity.
It has to be. It's a necessary safety mechanism for trauma triage.
But you mentioned that the FMERGE function also offers granularity within those color bands. Why is that important? Why does the system need to distinguish between, say, a patient with 1 red parameter versus a patient with 3 if they're both ultimately triaged as red?
This granularity is essential. It's for resource allocation and for clinical prioritization within that red category. Think about it. 2 patients arrive at the same time, both coded red. Clinically, we know that the patient with respiratory failure, severe bradycardia, and profound desaturation is significantly more unstable, probably closer to cardiac arrest.
Than the patient who is just severely tachycardic.
Exactly. And the Verger function has to reflect that difference. To do that, the function incorporates the cumulative effect of the intermediate scores. We quantify this by summing numerical codes. Green is 0, orange is 1, red is 2. With three parameters, this system results in distinct subintervals. As you noted, there's only one possible green subinterval when all parameters are 0. There are three possible orange subintervals. But crucially, there are five possible red subintervals. The SHRO score precisely maps the sum of those component codes to these intervals.
So a patient with one red flag scores lower in the red band than a patient with three.
Precisely. A patient with one red component and two green components, a code sum of 2, will score at the lower end of the red band, specifically 67 to 73.6. However, a patient with three red components, a code sum of 6 scores in the highest possible band, from 93.4 up to 100. This highly granular output gives immediate information to clinicians. It's not just red needs urgent care, but red potentially imminent collapse, or red critical but maybe stabilizing. It allows for far more nuanced clinical judgment than a simple binary red-not red classification.
That level of detail really does transform the score from a simple triage flag into a dynamic indicator of physiological load. So let's move from the mathematical model into the real world. How was this SHRO scoring system actually validated? What did the pilot study reveal about its practical performance against an experienced physician's judgment?
The validation involved leveraging real-life continuous data. This was gathered from 84 major trauma patients who were admitted to the intensive care unit at La Timone Teaching Hospital in Marseille. The methodology was a retrospective, blinded comparison. We compared the continuous automated SHRO score classification, green, orange, red, against the independent simultaneous cutter classification that was determined by experienced medical staff. They served as our clinical gold standard reference.
And you were looking at the initial assessment before interventions started confusing the picture.
Exactly. We focused on the initial assessment time points before medical interventions or sedation began to alter the pure physiological response. The results were, well, they were encouraging and sobering in equal measure. Across the entire database of 84 subjects, the prediction success rate, or PSR, was 74%. Yes, so that means 62 of the 84 subjects were correctly triaged by the automated system. Statistically, that's relevant. It validates the basic methodology. However, the study immediately highlighted the inherent weakness of using only those three primary parameters in complex trauma cases. We observed a distinct category of subjects, those with severe neurological lesions or those with acute alcohol intoxication, where the SHRO score really struggled.
Why was that?
Because the patient's severe state was being driven primarily by central nervous system compromise, which isn't immediately or drastically reflected in just heart rate, respiratory rate, or SpO2. So when we filtered out those specific subjects, the PSR rose significantly to 77%.
Ah, okay. That's a key finding.
It's a very sharp improvement, and it tells us that the score is robust for general trauma and physiological instability, but it is currently blind to a primary neurological catastrophe.
A 77% accuracy rate on the non-neurological population is a strong foundation. But in critical care, 77% isn't good enough. That still means roughly 1 in 4 patients might be misclassified. Did the confusion matrix analysis give you any insight into the nature of the errors? Was the system generally erring on the side of caution, or was it underestimating severity?
This is perhaps the most crucial takeaway for any future development. The analysis showed a very clear bias. The system tended to underestimate the severity. We found, for instance, that 10 subjects whom the physicians classified as red were incorrectly flagged by the automated system as orange. Only 2 subjects were overestimated, so orange classified as red.
And clinically, that underestimation is a huge risk.
It's a high-risk finding. In a mass casualty scenario, if you miss classifying a critical red patient and you downgrade them to orange, that fatal medical mistake could be the difference between life and death due to delayed care. Therefore, the future refinement of the SHRO algorithm must incorporate a deliberate bias towards overestimation. It's always safer to triage an orange patient as red than the other way around. It ensures they receive the highest level of scrutiny.
Okay, let's look at the individual components. Did the validation process confirm that clinical suspicion that respiratory rate is often the earliest, most reliable indicator of instability?
Absolutely. We first confirmed the statistical independence of the parameters. Heart rate and respiratory rate showed a slight correlation about 0.49, but SpO2 was largely decorrelated. This confirms they're capturing unique physiological information. But the real clinical insight came when we tested the predictive success of the individual parameters without allowing the system to optimize the threshold limits. The respiratory rate, the RR, demonstrated the highest single parameter PSR at 57%. 57%. Heart rate followed at 47%, and SpO2 was the lowest at 39%.
And that backs up what clinicians have seen at the bedside for decades.
It statistically reinforces it, yes. The body compensates for volume loss, for shock, by increasing heart rate, but often the most immediate, critical compensation involves changes in ventilation to manage acidosis. An elevated or depressed respiratory rate is often the first physiological domino to fall. That makes it a powerful early detection mechanism for instability, which is why its high PSR is so significant.
That distinction is paramount. And this all highlights the ultimate value proposition here, doesn't it? Continuous monitoring versus manual spot checks. Can you walk us through a couple of the case studies from the pilot data to illustrate exactly how this dynamic tracking is so superior to a static evaluation?
Yes, let's look at the continuous monitoring traces. This is where the SHRO score truly sells itself. It shows the evolution of a patient's status over minutes, not hours. Take subject A. This was a trauma patient actively receiving care in the ICU. When we monitored the continuous trace, the global score decreased sharply from a critical 78% deep in the red zone to about 33% right on the orange-green border. And this happened over about 10 minutes.
So you can actually see the treatment working in real time.
Precisely. It was an objective quantification of the positive response to intervention. The heart rate and respiratory rate scores rapidly dropped from high red and orange levels back towards the green range. This provided immediate objective feedback to the medical team that the patient was stabilizing. It allows them to adjust care with confidence based on dynamic data rather than just waiting for the next scheduled manual check.
And what about a deteriorating patient?
Well, contrast that with subject B, whose condition was highly volatile. Over a 13-minute monitoring period, this patient experienced significant physiological fluctuation. At one point, their heart rate increased rapidly, from 95 to 125 beats per minute, pushing their intermediate heart rate score to a red level of 68%. But more critically, their SpO2 dropped dramatically, reaching a critical low of 81% around the 6-minute mark.
And the system caught that instantly.
Instantly. The drop caused the SpO2 score to spike to 81%, deep in the red. Consequently, the global SHRO score fluctuated sharply between orange and red in real time. This is the difference maker. The system detected and flagged that critical drop in oxygen saturation the moment it occurred. A manual check performed 10 minutes later might have found the patient already requiring advanced intervention.
That dynamic detection capability is clearly vital. So, looking ahead, if 74% is the current baseline and the ultimate goal is near-perfect accuracy for wide clinical adoption, what are the 2 or 3 most critical, non-negotiable enhancements needed for the SHRO scoring system?
Well, as we've established, the score has to be flexible and scalable, which the FMERGE function is designed to facilitate. The first, and I think the non-negotiable enhancement, is the integration of neurological status. The 77 versus 74% difference speaks volumes. We must move beyond simple GCS assessments that require human interaction.
So you need passive, continuous neurological proxies.
Exactly. This involves leveraging advanced wearable sensors to capture, for instance, motion level. Detecting absolute immobility can be a simple but powerful proxy for severe unconsciousness or paralysis. And beyond that, autonomic metrics. We need to incorporate electrodermal activity, or EDA, which measures skin conductance changes reflective of sympathetic nervous system activity.
Stress, pain, fear.
Yes, all of that. And heart rate variability, HRV, which quantifies the balance between the sympathetic and parasympathetic systems. Changes in HRV are powerful, objective markers for pain, shock, and central neurological compromise. They offer true physiological insight. Secondly, the algorithm itself needs to be recalibrated for caution. Given that tendency to underestimate severity, the weighting mechanism within the FMERGE function has to be tuned. It needs to adopt a more conservative, safety-first stance, ensuring any ambiguous case defaults upward to the highest level of urgency.
And finally,
depending on the orthopedic trauma setting, the score needs to evolve to incorporate inputs that address specific clinical risks, perhaps a derived hemorrhagic risk function using pulse wave amplitude, or even basic inputs like age and comorbidities.
to make these sophisticated enhancements possible, we need sophisticated hardware. Let's transition to the technology that actually captures this data. The future of a score like SHRO relies on flexible, accurate, non-invasive sensors. What are the current breakthroughs in sense technology that enable this kind of continuous, high-fidelity data collection, particularly within an orthopedic context?
The foundation is really built on breakthroughs in flexible electronics and what we call polymer nanocomposite sensors. These allow devices to conform to the body, to integrate into clothing, orthotics, even surgical dressings. We tend to categorize these into physical and physiological sensors. In orthopedics, physical sensors are key.
So things that measure movement and pressure.
Exactly. These are electromechanical devices that detect minute pressure changes, like a pulse wave or large joint movements, range of motion, and gait analysis. They can be built into smart shoes for rehabilitation tracking or integrated into flexible patches for continuous monitoring. The underlying sensing mechanisms are quite varied. One of the most widespread is the piezoresistive effect.
Piezoresistant.
Yes. This involves materials where the electrical resistance changes dramatically when they are mechanically deformed or strained. In these polymer nanocomposites, so think of flexible materials embedded with carbon nanotubes or silver nanowires, the strain causes the conductive pathways inside the material to break or change their tunneling distance, leading to a measurable change in resistance. It's highly effective for detecting physical pressure and minute movement.
Okay, so piezoresistive is about resistance changing due to physical force. Can you clearly distinguish that from the other two piezo technologies we often hear about, piezocapacitive and piezoelectric?
Certainly. The piezocapacitive sensors measure changes in electrical capacitance rather than resistance. So when the material is strained, its physical dimensions change. The distance between the conductive plates and their area of overlap changes, and that in turn alters the capacitance. This is often leveraged in pressure mapping and touch sensing. The piezoelectric effect is fundamentally different. It's an intrinsic property of specific materials, like PVDF films or certain ceramics. When you mechanically strain these materials, they generate an actual electrical charge or voltage difference without needing an external power source.
So they power themselves, in a way.
In a way, yes. They're ideal for vibration detection and for harvesting energy from motion, but they often require more complex signal conditioning than piezoresistive sensors. And finally, we have the fascinating triboelectric sensors. These leverage the triboelectric nanogenerator concept, or TEAS. They generate electricity based on the friction between two different materials. Crucially, they harvest energy from mechanical motion like walking, joint flexion, even breathing. This mechanism is key to developing self-powered systems, allowing the sensor to operate continuously without relying heavily on a battery.
That self-powered aspect is a massive advantage. But for the clinical end user, for the surgeon or the physio, the quality of that data is defined by performance metrics like stretchability and sensitivity. You mentioned there's a trade-off here. Why does high stretchability often compromise sensitivity, and why does this matter in practice?
It's a fundamental engineering challenge. Sensitivity is often measured by what's called the gauge factor, or GF. This dictates how much the electrical signal changes for a given amount of strain. To have a high gauge factor, you want the internal conductive network to be extremely fragile and sensitive to physical stress.
So it reacts to the tiniest movement.
Exactly. You want it breaking contacts or dramatically widening tunneling gaps very quickly. However, to achieve high stretchability, say 500% stretch without damage, which you'd need for an orthotic device on a moving joint, you want the internal network to be resilient, flexible, and robust. And that directly contradicts the requirement for high sensitivity.
They're pulling in opposite directions.
They are. Simple, thin film structures often fail this test. And this matters clinically because of precision. A physiotherapist needs a sensor on a knee brace to accurately detect a subtle 2-degree increase in range of motion. That's high sensitivity. But the patient must also be able to perform dynamic full-range exercises without the sensor breaking or giving erroneous readings. That's high stretchability and robustness. So engineers have to use sophisticated techniques like nanostructuring the conductive materials or designing specialized microcracked patterns to try and maximize sensitivity while keeping the material ultra-flexible for real-world patient use.
So we have the hardware generating this vast, continuous, high-fidelity data. We're talking hundreds of thousands of data points per patient per day. This is the point where human capability is completely surpassed, isn't it? Which makes the AI layer absolutely non-negotiable. Can you explain the multifaceted role of artificial intelligence and machine learning in translating this overwhelming volume of sensor data into something clinically meaningful?
AI is the indispensable bridge between that raw physiological signal and an actionable medical insight. Its role can really be broken down into three critical areas. Firstly, data processing and error correction. Wearables are noisy. Movement artifacts, incorrect placement, electromagnetic interference. They constantly pollute the data stream. So AI algorithms are essential for processing these massive continuous streams, for filtering out the noise, and vitally for correcting errors. A machine learning model can analyze the pattern of raw heart rate data from a wrist sensor, recognize movement-induced errors, and mathematically reconstruct the true, accurate heart rate trajectory.
So it's cleaning the data before it's even analyzed.
Precisely. It significantly enhances the fidelity of the input data for systems like SHRO. Secondly, there's prediction and pattern identification. And this is the most exciting area. AI moves beyond simply reporting the current status. It forecasts the future status. Deep learning algorithms, which use multi-layered neural networks like recurrent neural networks or RNNs, which are fantastic at processing time series data, can analyze complex, subtle shifts and patterns that a human clinician could never spot. They can combine data points like sleep quality, activity levels, heart rate variability, respiration trends, and use them to forecast health outcomes.
Give me an example in a trauma context.
For a trauma patient in recovery, an AI model could flag subtle changes in their HRV and sleep patterns that indicate a high probability of impending sepsis or a cardiac event, hours before standard physiological markers would cross a critical threshold. This enables truly proactive, preventative intervention. And thirdly, there's personalization and optimization. AI customizes the patient experience. In trauma or orthopedic care, an AI model can learn a patient's individual baseline and only alert when a deviation from their norm occurs, rather than from a generic population threshold.
That's a huge step forward.
It is. And furthermore, AI can optimize algorithms like the SHRO merging function by analyzing millions of data points to constantly refine the weighting of parameters, ensuring the score is always performing at its peak accuracy for diverse patient cohorts.
That covers the acute side brilliantly, the triage and the prediction. Let's pivot now to the recovery phase, which, as we discussed, is plagued by adherence issues. When a patient leaves the hospital after a complex orthopedic procedure, they're often given this demanding rehabilitation regimen, and the evidence suggests they frequently fail to follow it. How severe is this adherence crisis?
The adherence crisis is chronic, and it's costly. Systematic reviews focusing on patients recovering from traumatic bone injuries, ligament reconstructions, joint replacements, they consistently report compliance rates ranging from as low as 35% up to 76%.
So a huge failure rate.
A huge failure rate. And it directly translates to poorer long-term functional outcomes, delayed recovery, and increased healthcare expenditure due to complications or readmissions. The barriers are mostly psychological and logistical. Patients lack motivation because home exercise is often tedious, painful, and it lacks immediate feedback. They lack confidence because they worry they're doing the exercises incorrectly without supervision.
And just the hassle of it all.
And the logistical hurdles, exactly. The cost, the time, the inconvenience of repeated, frequent visits to a physiotherapy clinic, especially for rural or elderly patients. We really need a solution that bridges that gap between structured clinical therapy and unsupervised home exercise.
And the proposed solution that leverages this digital technology is the implementation of so-called serious games. Could you define that concept for the listener? How is it different from just playing a commercial video game?
A serious game is not just entertainment. It's an interactive, often immersive computer application that incorporates elements of traditional gaming like challenge, scoring, objectives, fun, but it has a primary non-negotiable goal of achieving a real-world outcome. In our case, that's improved mobility or strength or range of motion. Historically, a lot of the research has relied on off-the-shelf commercial motion sensing consoles, things like the Nintendo Wii, which uses basic accelerometer controllers, or the Xbox Kinect, which uses depth cameras.
But they weren't designed for clinical use.
Not at all. And while they proved the concept, they weren't engineered for the precise movements and data recording requirements of clinical physiotherapy. For example, a game designed to get a patient to squat might be fun on the Wii, but the system doesn't accurately measure the angle of their hip flexion or the load on the joint.
So when researchers have reviewed the use of these serious games in traumatic bone and soft tissue injury rehab, what do the systematic reviews reveal about their efficacy? How do they stack up against traditional physio in terms of functional outcomes?
The consensus is actually quite positive, though it's often caveated by the quality of the available trials. Serious games are consistently found to be a safe and viable alternative or addition to conventional physiotherapy. Crucially, the functional outcomes achieved by the game groups, measured by metrics like range of motion, strength, or validated scoring systems, were generally comparable to those achieved by the standard therapy groups.
So you're not losing any therapeutic benefit.
Exactly. You can achieve similar therapeutic results while significantly boosting engagement. We do have some specific examples of functional benefits. One randomized controlled trial on total hip arthroplasty patients found a statistically significant improvement in the Harris Hip Score, a critical functional outcome measure, in patients who incorporated a cognitive training game, specifically Dr. Kawashima's brain training, alongside their physical regimen.
That's interesting, a cognitive game helping physical recovery.
It is, isn't it? It suggests that the cognitive engagement provided by the game positively influences the whole recovery process. Even more compelling is the use of movement-based games to address pain. A study involving burn patients who often face excruciating rehabilitation showed a statistically significant decrease in pain scores when they used Wii balance board exercises. The immersive, distracting nature of the game seems to offer a kind of psychological analgesic effect, making the necessary but painful exercises more tolerable.
That connection between functional improvement and reduced pain is highly relevant. But the ultimate clinical goal here is driving that patient compliance. Was there concrete, measurable evidence that serious games significantly increased the amount of time patients actually spent exercising?
This is where the data becomes highly focused but extremely powerful. Out of several systematic reviews,
Yeah.
one specific study demonstrated a statistically significant advantage in self-reported exercise duration. This trial focused on upper limb burn rehabilitation and compared a game group using the Xbox Kinect to a conventional therapy group. And the difference was striking. Patients in the game group reported exercising for an average of 49.3 or 7 minutes per session.
Nearly 50 minutes.
Nearly 50 minutes, compared to only 26.7 minutes for the conventional therapy group.
Wow, that's almost double the exercise duration.
It's a phenomenal increase in the therapeutic dose. And this single, highly positive data point strongly supports the hypothesis that including these gamification elements, the score, the immediate feedback, the challenge, the fun, can dramatically boost patient motivation and self-management, effectively mitigating that chronic adherence issue.
That 49-minute figure versus 26 minutes is incredible. But as you noted, the current research is built on repurposed, off-the-shelf consoles. The real future, and the key gap in current research, surely lies in combining the custom, flexible sensors we discussed earlier with games that are specifically engineered for rehabilitation protocols. How does marrying these two technologies, wearables and bespoke, serious games, unleash the full potential for orthopedic telerehabilitation?
This is the convergence point. This is where it all comes together. The limitation of the current research is that the systems lack true clinical precision and objective, continuous monitoring. If you use a Wii, you know the patient is moving, but you don't know if they're achieving the prescribed 90-degree flexion, or if they're compensating with an incorrect movement pattern. You're guessing.
You're guessing. The integration of bespoke, wearable sensors changes everything. Imagine flexible, piezoresistive sensors embedded in a knee brace or a soft ankle orthotic. These sensors provide objective, continuous metrics, precise range of motion data, load-bearing velocity of movement, all fed directly into the serious game application. And this combination unlocks genuine personalization and feedback. The game no longer relies on approximation. It can give the patient instant corrective feedback. You are compensating with your hip, adjust the angle of your knee to achieve the goal score. It also provides the clinician with a remote objective report of compliance and progress, which is essential for effective telerehabilitation. This personalized, engaging, and objectively monitored approach is the future of maintaining compliance, optimizing resource use, and facilitating patient independence during recovery. We've painted a picture of immense technological promise here, spanning acute trauma triage with the AI-driven scoring like SHRO, right through to chronic rehab management using games and wearables. But this isn't science fiction. We have to address the practical, real-world hurdles. What are the primary clinical, technological, and ethical challenges that are inhibiting the widespread adoption of these AI-enabled wearables in medicine today?
The challenges are significant, and they must be addressed rigorously before these systems can be fully integrated into high-stakes clinical workflows. The first challenge, and perhaps the most complex, is clinical validation and standardization. Currently, there's a lack of standardization in data acquisition across the myriad of available devices. If device A measures heart rate variability one way and device B uses another, comparing their clinical efficacy is challenging.
It's not comparing apples with apples.
Not at all. For medical-grade adoption, we must move away from proprietary consumer devices toward validated, FDA or CE-approved medical wearables. Rigorous testing is essential to confirm they function reliably not just in a stable hospital environment, but in the chaos of pre-hospital and mass casualty conditions. And the risk of algorithmic failure. It can't be understated. As we saw with SHR, we need to avoid false positives, which cause unnecessary alerts, and critically false negatives, which means missing a critical condition. That demands exhaustive scrutiny and validation trails.
And what about the hardware itself, the technical constraints?
On the technical side, the primary hurdle remains power management. Continuous, high-frequency data collection from multiple sensors, combined with the continuous processing of sophisticated deep learning algorithms. It all places an immense strain on battery life. For a patient wearing a device for 24/7 monitoring, constantly having to recharge it is just indeed. Regarding security and data integrity, these devices handle the most intimate physiological data imaginable: heart rate, sleep cycles, location, and soon, biochemical markers. When these wearables connect to smartphones and third-party cloud apps via protocols like Bluetooth or Wi-Fi, vulnerabilities are introduced. Protecting this sensitive health data from malicious breaches is paramount. We need robust end-to-end encryption, strict data anonymization protocols, and clear regulatory guidelines on data ownership and access. These are essential ethical and practical requirements to build patient trust.
So if we can successfully navigate these challenges and this digital transformation proceeds, what is the ultimate philosophical shift in healthcare that we're moving towards? What's the overarching model that connects AI triage, smart orthopedics, and personalized recovery?
We are converging on a future healthcare model known as P4 medicine. This framework fundamentally reorients the focus of medicine away from the reactive treatment of disease toward the proactive management of health and well-being, leveraging digital technology at every single step.
P4 medicine.
Yes. The 4Ps describe this shift. First, predictive. Utilizing AI and continuous biosignal analysis to forecast the likelihood of future health events. For an orthopedic trauma patient, this isn't just predicting a heart attack. It's predicting the risk of a delayed union, of infection, or of chronic pain based on continuous motion and inflammation biomarkers. And that allows for preventative action, which brings us to the second P, preventative. Moving beyond early diagnosis to intervention before a condition even fully manifests. In trauma, this is the continuous monitoring that detects subtle signs of decompensation long before a manual check would catch it. In rehab, it's the system spotting aberrant movement patterns that could lead to a secondary injury and offering immediate correction via the serious game interface.
The third P must be personalized.
Personalized, exactly. Tailoring treatment and care plans precisely to the individual's unique physiological response profile. This means custom rehab routines based on their actual rate of improvement or AI-driven dose adjustments for medication based on continuous vital sign monitoring. It moves us away from generalized population statistics. And finally, the fourth P is participatory. This is the most patient-centric P. It means empowering the individual by giving them real-time objective data about their own health and progress. Technologies like gamified telerehabilitation dramatically increase patient involvement, making them active, engaged co-managers of their own care journey rather than just passive recipients of treatment.
This has been an extraordinary deep dive. We've mapped the technological landscape from the mathematical rigor needed to design the automated SHRO trauma score highlighting that need to integrate crucial neurological markers like EDA and HRV, all the way to the potential of using these same wearable platforms, combined with serious games, to radically improve adherence in orthopedic rehabilitation. The overarching message seems clear. Digital technologies are rapidly transitioning from being mere adjuncts to becoming integrated, diagnostic, and therapeutic platforms. This demands immediate attention and understanding from mid-senior medical professionals across orthopedics, emergency medicine, and critical care. If you found this discussion valuable for your clinical practice or professional understanding, please take a moment to rate and share our deep dive with a colleague.
And perhaps to leave you with a thought that captures the speed and intimacy of this technological evolution. As AI biosensors expand beyond blood and sweat, and they are now capable of analyzing tears, saliva, and interstitial fluid for multiple complex biomarkers, how will we manage the ethical and practical responsibility of continuous multi-biomarker monitoring when the data accuracy derived from the wearable approaches or even surpasses the nuanced clinical assessment of a human physician? What does clinical judgment even mean in the age of constant data?
A profound question for the future of patient autonomy and clinical governance. Professor Imam, thank you for guiding us through this essential deep dive.
My pleasure.
We'll see you next time on Deep Dive Ortho.